Southwest, Dr. Jackie Armani, the lead MSL for the Northeast, and Dr. Michael Petrick, the lead MSL from Canada. We're going to be collecting the questions during the session and present them to the doctors so they can answer them. We're also going to try to reserve time at the end of the session for questions as well. If for some reason we don't get to your question during the presentation, a member of the MSL team will reach out to you to address your questions. I'd like to introduce the surgeons for the sessions today. Dr. Mark Lobanoff is Director of Refractive Surgery at the North Suburban Eye Specialists in Minneapolis, Minnesota. Stephen Wexler has been performing refractive surgery since 1991. He's clinical professor of ophthalmology at Washington School of Medicine and works at TLC Laser Centers in 4 locations: St. Louis, Fargo, Bismarck, and Billings. So he's busy. Also, both are strong research partners for Alcon, having been involved in a number of investigator-initiated studies. It's my pleasure to introduce both Dr. Lobanoff and Dr. Wexler. Take it away.
Well, thank you so much, Dr. Breen, and thank all of you for joining us this afternoon. We hope you have been well and are safe in our suite. So Mark, why don't you take it over and tell us about the Contoura FDA study?
Absolutely. So Alcon wanted to show the FDA that Contoura was safe, and so the study was conducted looking at patients with myopia and myopic astigmatism. Try to advance here. We can advance the slide. The design was a 1-year study looking at 9 investigational sites within the United States. A total of 249 eyes were used in the study. And you can see that the criteria match up very much with what we're clinically going to be doing here in the United States in terms of treatments. One thing that has to be kept in mind about the FDA study, though, is before a cornea was allowed into the FDA study, no fewer than 3 cornea specialists evaluated the corneal topography and made sure that cornea was perfect, had very little irregularity. And in choosing these perfect corneas for the FDA study, the measured corneal astigmatism matched up very closely with the manifest astigmatism for these patients. Next slide, please. The results of the study, we all know, were excellent. One of the things that came out of the study was showing that there was stability over time. So not only did patients see well at the 1-month mark, but they continued to see equally well at 3 months, 6 months, and even 12 months out. You can see that the mean refractive spherical equivalency was excellent throughout the time period and actually improved slightly at 12 months out. Next slide. Here we're looking at the post-operative uncorrected visual acuity for patients, really focusing on what matters the most, the teal at 1 year. You can see that 93% of the patients within the study had 20/20 or better vision uncorrected at 1 year. A very high percentage, 65, were seeing 20/16 or better. And what was truly astounding about this study, 1 in 3 patients, 34%, were seeing better than 20/15, 20/12.5 at 1 year out. So these were very impressive results. Next slide. In addition, we saw a decrease in the overall amounts of higher order aberrations, with the RMS decreasing by 8.9%. Patients also, for the first time ever in an FDA study, showed statistically significant decreases in a lot of the post-operative complaints patients had previously had about LASIK. Light sensitivity, difficulty driving at night, reading difficulty, glare, all these things were shown to be decreased in patients who have been treated with the Contoura technology. Next slide. So the conclusions were this was a surprising study in just how good the results were. We saw 93% of eyes seeing 20/20 or better, 16% of eyes seeing 20/10. Patients were seeing not only better on the chart, but the quality of their vision, the complaints about other issues were down. So this gave us a lot of enthusiasm. I was very enthusiastic to bring this into my practice. Stephen, when finally the tires hit the road, what happened?
So I started using Contoura in April 2016, and I was very excited. You know, when I saw these results and 2/3 of eyes seeing 20/15, you know, with Wayfront Optimize, first of all, we have to understand Wayfront Optimize is an excellent technology. We were getting incredibly good results. So it was going to be hard to improve upon that. but I was usually running around 30, 35, 40% 2015. And I do track all my data and keep pretty darn good track of sort of where things are. So when I first came to using Contoura, I was excited. I thought it was great. It was a little onerous because, you know, with the wavefront optimized, we just put in our nomogram adjusted refraction, and it's easy. This took a little bit of a learning curve. Yeah. And results were very good. But to be honest, they weren't much different than I was getting with wavefront optimized. And moreover, on occasion, you could have some outcomes that were unexpected. And so we started all thinking and looking about ways to improve how to program the laser. I sort of look at Contoura as I look at my iPhone. You know, my iPhone does more than I will ever know how to do. They publish magazines on all the little tricks and things you can do with your iPhone. Well, that's how I feel about Contoura. You know, it does so much, and I'm just not sure I understand it 100%. So that's where I was at that point. So as you know, Dr. John Kanellopoulos came out with a study in 2016 looking at TMR. Mark, will you explain what TMR was, and did you start using it?
I did. John is just a tremendous surgeon. I've got so much respect for him. And he had looked at this and said, Mark, I'm getting better results. Instead of treating off the manifest astigmatism, I'm looking at the measured anterior corneal astigmatism, the magnitude and axis, and I'm treating off the magnitude and axis of the measured anterior corneal astigmatism. And many times in my patients, this differed from what the manifest was saying. So it was a little daunting. It was a little scary. Sometimes these would differ by 20 degrees, 30 degrees, 50 degrees in axis. Magnitudes could differ quite a bit. But John was right. If I treated TMR, topography modified refraction, treated off the measured anterior corneal astigmatism, I got better results at the 20/20 level. And finally, I was catching the FDA results at the 20/20 level. But at the 2015 level, I was still only getting about 50% of my patients to the 2015 uncorrected, as they did in the FDA study. And so I felt like I was still missing that last critical component.
So I sort of felt like you. I used TMR, and to be honest, I was a chicken. I mean, it was hard to put in the entire measured sill for fear of flipping the axis. As we all know, that if you were to flip an axis on a patient that's used to having with the rule astigmatism to against the rule, often they don't like that. Right. So I was nervous. So in conjunction with Tim Giles in Texas, I developed what's called the 50-50 method, or the half sill method. And let me just describe that to you as quickly as I can. We basically took the delta between the measured and the manifest, and we started off using half of that number. So if the manifest sill was 1 diopter and the measured sill was 2 diopters, we would start with 1.5 diopters, and that's sort of what we would use to program the laser. But then we took it another step. We looked at the image of the higher order aberrations. And we're going to show that a little later in this talk. We'll show that if you zero out the sphere and the sill, you get a map of the higher order aberrations. And these maps are all unique and they all look different. So I used to look at that map and say, gosh, there's a lot of horizontal coma on this eye. And if I correct that horizontal coma using Contoura, it's like correcting with the rule astigmatism. So if my starting point was a diopter a half of with the rule astigmatism, and I see a bunch of horizontal coma, I would lower that 150 to a 125. But to be totally honest, it was a total guess. You basically could right click on the little elevated area of irregularity, and you could see how many microns of tissue were removed and get a feel for how that coma was going to affect the patient's manifest refraction. So that's sort of where I was, but I never really felt comfortable with it. It was hard for me to teach it to my optometrists that I work with at my 4 offices. And I was so pleased in the fall of 2018 when you called me and said, I've got this program that I'm developing. Would you be a beta test site and let me use you as a guinea pig? So I was happy. I was looking for something. And frankly, what you did in developing this software was really brilliant. So I would like you to sort of talk about how you developed Forcides and what you were thinking at the time.
Sure, we can go to the next slide here. As you said, you've been looking at the topography. So as you're planning your treatment in Contoura, you're zeroing out the sphere and cylinder. And in the planning station, that brings up the purely topographic treatment that's going to be applied to the cornea. And I would try to figure out how different features might affect cylinder and sphere. The problem was it was shooting from the hip, and it would change day by day, and it was very difficult to teach. So I said, we need to look at this a different way. We need to have an analytical, more precise, mathematical way of looking at things. And at ESCRS in Portugal, I happened to get on the wrong tour bus. And instead of touring Lisbon, it took me out to the coast to a place called Cabo da Roca. And Cabo da Roca is this area of Portugal where the mountains are cascading down into the ocean. And there's all this beautiful topography, these hills and mountains. And I thought to myself, how does the real world analyze topography? And when I got back to the US, I realized there's software that helps with that. And the software is called geographic imaging software. What GIS software can do is it can take 2-dimensional maps that represent 3-dimensional structures, and it can pull all sorts of technical data out of that 2-dimensional map. And I really said, this is what Alcon's giving us. They're giving us a 2-dimensional map representing a very complex 3-dimensional cornea. We're going to show you guys that in a minute or two. And sure enough, the GIS software could be applied to those maps. Then my team, we worked out what were the optical effects of different topographic irregularities of different sizes, heights, radius from the center. And then we could standardize all that. And we could use mathematics, vector mathematics. We could add in vectors for the anterior corneal astigmatism, the posterior corneal astigmatism. We could determine lenticular astigmatism. And then finally, we could put everything together and tell the surgeon, here's precisely the sphere, cylinder, and axis that you should be treating.
So define for us, Mark, what's a talus?
Going to be easier to show you in a few slides, but to just kind of give you a short take on things, I got tired of talking to surgeons and saying, we're talking about topographical irregularities. It's just hard to say. So because we're borrowing software from geology, I thought we would borrow a term from geology called a talus. And if you have a mountain or a hill, and then you have a collection of debris on that hill that forms a secondary smaller slope, this is called the talus. And I said, that's really exactly what we're dealing with here on these pictures. We've got the overall corneal curvature, and then you've got certain areas of elevation and depression on that topographical map. So those areas of elevation we refer to as talus. We'll be able to show you that in just a few slides.
So if you've got a patient that's got a big difference in both axis and in power of their manifest cylinder and their refraction and their measured sill, what are the possible sources of that difference?
Typically, the sources are going to be either from the topographic features, the taluses, or in rare cases, significant amounts of posterior corneal astigmatism. In other cases, lenticular, internal astigmatism. So we have to, when there is a difference between the manifest astigmatism and the anterior corneal measured, something is causing that discrepancy. And we have to explain that to the surgeon, understand it in our calculations for treatment before we treat the patient.
And you really do that by vector analysis. Is that correct?
That's right. So we create a series of vectors. Again, there's one vector for the anterior corneal astigmatism, one vector for the posterior corneal astigmatism, a series of vectors for each talus. We calculate the lenticular astigmatism. It may have a vector. And then the software puts all that together using vector addition and subtraction mathematics to give you the correct answer.
My next question is very important. Were you really good at math in high school?
Up until, yes, yeah, pretty good. I,
Well, hopefully you had some help in developing this. So let's talk about some clinical studies. So you did a